Good day. My name is Imelda Williams. I'm going to give you a brief overview of how to complete the clinical portfolio. I would also like to just give recognition to Tony Smith, who is the co-convener for this unit. Monash University recognises that its Australian campuses are located on the unceded lands of the people of the Kulin Nations and pays its respects to their elders past and present. I've given you here our contact email. So the email, of course, our Monash email. So that is the best way to get hold of us. So the resources, of course, will be the Moodle site. And on the Moodle site, under week 1, which starts the 3rd of March, you will find this clinical portfolio Moodle book that has got all of the other information. As you progress through the course, other information you gather from the other Moodle books that's going to be presented through this unit will also be useful for you to complete the clinical portfolio. This introduction PowerPoint presentation will be found under week 1, starting 3rd of March. So the clinical portfolio is a competency hurdle, and that means that if you do not pass it at first instance, you'll get a second opportunity to resubmit, but that will, of course, be capped at 50%. The overall weighting for the clinical portfolio is 30%, and you should have a minimum of 25 clinical cases, so a range of clinical cases applicable to this unit. And then there's a second part to it, and that is the self-auditing PIE record, and that is where you're going to do a bit of statistics. The submission deadline for the clinical portfolio is on Monday, the 23rd of June at 5 to 12 in the evening. So just focusing then on the first part, which is the clinical case submission. So your 25 cases, each case is worth 4 marks. So in total, that part of the clinical portfolio is 100 marks. The overall word count is 2,000, which roughly equates to about 80 words per case, but don't stress too much about that. Some cases you'll use less words and some others you will use more. And of course, for this unit, the body regions that you have to cover is the cervical spine, the shoulder girdle, and the upper limbs. You can use references, especially if you want to support your discussion. However, that is not a specific requirement. As this requires your knowledge to be displayed and understanding of the clinical cases and image interpretation, you are not allowed to use generative AI. So in the clinical case, you will include the mechanism of injury or clinical signs and symptoms, should at least have one de-identified image. You can have more than that, of course, and then write up your preliminary image evaluation before you look at the radiologist's report. And once you've done that, then compare to the radiologist's report. So compare and contrast that. And if applicable, and again, this is not a specific requirement, you can include patient immediate management. The marking rubric for the clinical cases is seen here. So the criteria then is you should have the history with presenting symptoms or mechanism of injury. And the second thing you need to think about is, because we encourage you to use a systematic approach, is to use the ABC search strategy. However, for each case, only use the ABC that's applicable to the case. So say, for example, if there is a fracture, you would obviously mention bone. And if there is misalignment at the fracture site, you would include A for alignment. But if there's no other signs, like the joint is not involved, so you don't need to include all of that. And then compare your PIE to that of the radiologist. And also, as I mentioned, you can include patient management, but that is not really a requirement. And then you must include at least one de-identified image. So the maximum marks for each case is 4 marks. So as mentioned, overall, with your 25 cases, this part is worth 100 marks. And here's an example of how to write up a case. So the important thing is to identify which case number you're talking about. So here I've got it as case 12. Identify the body region. So this is a forearm, and then the clinical indications. Here is a foot injury, and then at least one de-identified image. So the preliminary image evaluation that was written up here stated there is a comminuted fracture to the distal radius with dorsal displacement, and there is an associated ulnar styloid process fracture. So compared to the radiologist's reports, it indicated there's an acute comminuted intra-articular fracture of the distal radius impaction and marked dorsal angulation. And there's also a transverse ulnar styloid process fracture with mild displacement. So between the two reports, both reports identified the two fractures. However, one of the very key findings was that the radiologist mentioned that this is intra-articular, which is a significant finding. So when you write up then your result, so your true positive would be 0.75. And then false negative for missing out on that pathology is 0.25. So the sub-auditing PIE record, so you'll have your 25 PIE reports in a table. And so the overall marks for that record is 20. And of course, it should only cover the body areas applicable to this unit, which is the cervical spine, shoulder girdle, and upper limb. And then for the PIE report, I've mentioned the clinical question. So if it is related to trauma, you only need to compare those PIE findings that is relevant to that of the radiologist report. Because quite often when you look at the radiologist report, they write much more. They will include other findings such as maybe osteoarthritic changes, which is not relevant, and that part you can ignore. Then assign whether your case is true positive, meaning that both you and the radiologist correctly identified the pathology. And true negative is where both you and the radiologist correctly identify that this is a normal case. So false positive, that is where the radiologist does not include a pathology that you have included. And false negative is where you incorrectly do not mention a pathology. So you might have to assign fractions. So here an example, there's two fractures and we only identified one. So you would assign half a true positive because that's where you and the radiologist agree, and then half false negative for not identifying the other pathology. Remember that each of your cases can only be equal to 1. And then for your calculations, you need to calculate the sensitivity, which is around identifying abnormals, specificity, which is around identifying the normals, and accuracy is your overall image interpretation accuracy between identifying normals and identifying normal cases. And then that part of it is equal to 15 marks. And then a brief reflection on your personal image interpretation abilities, and that is 5 marks. And you could include things like, for example, when you start off in this unit, you might have often incorrectly identified, let's just say, a pediatric elbow, but now over time, this has improved. So you could mention things like that, or that you are very happy with your performance throughout this unit, and that is also okay to write about. So as mentioned, just to summarize this in your proposed spreadsheet, so you'll allocate the true negative, true positive, false negative, and false positive. As mentioned, you might have to use fractions. Use your own judgment when you apply those fractions, but do remember that each case is only equal to 1. And then calculate the sensitivity, specificity, and accuracy. So this is what your spreadsheet should look like. You will, of course, add more rows. It's quite important that you also include normal cases, not just abnormal cases. if you have very limited normal cases, which is quite often the case because students tend to want to display the fact that they've identified pathology, it does affect the specificity. So say, for example, if you only have two normal cases and one of your normal cases that is not correctly identified, that will bring down your percentage in terms of specificity. Now, what's important is if you have 25 cases, if you add all of that up, it's 25. And then if you think that for each of your cases across the row for each cases, it can only add up to 1. So this bottom row, when you add all your true positive, true negative, false positive, and false negative, should also add up to 25. So this is just what we call a decision-making table, and that displays the radiologist report, which is of course seen as the gold standard versus that of the preliminary image evaluation report, and how you then assign your positives and negatives. So as mentioned, sensitivity, that's where you want to be able to identify abnormal cases, and you want to keep it as close as possible to 100%. So that abnormalities are not missed. So it means that you would strive to have very few false negatives where you do not actually identify the pathology. Specificity then is the ability to discriminate that these cases are normal. So here you want to eliminate false positives, so identifying pathologies that's not there. And the reason why it's important to keep your normals as high as possible to 100%, you might be working in an area where you are the sole radiographer and where your expertise is always called upon, and it could actually result in a higher risk of associated treating the patient or additional imaging that can result in additional radiation. So the accuracy is a ratio that displays how well you are in identifying pathology, as well as how well you are at identifying that the cases are normal. So it gives an overall reflection of your image interpretation skill. So in conclusion, make sure that you start collecting a range of clinical cases so you can cover all of the body parts. And then also do not forget that you also need normal cases as well. And then if needed, please feel free to contact either myself or Tony. Thank you.